The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Let's now go to Module 3, Cardiac Physiology. So if someone will ask you what is the purpose of the heart, you're going to answer this way. The sole purpose of the heart is to match the cardiac output with the venous return. Okay? The sole purpose of the heart is to match the cardiac output with the venous return. Venous return is the amount of blood returning back to the heart per unit of time. Venous return. Cardiac output is the amount of blood leaving the heart per unit of time. So the sole purpose of the heart is to match the cardiac output with the venous return. If this is not equal, then the heart has failed in its function. If this is not equal, then you're going to have heart failure. Okay? So kung ano yung pinasok mong dugo sa puso, yun din ang ilalabas mo. Cardiac output should be equal to your venous return. Okay? Now, let's take a look at some of these equations that we have here. Okay? The cardiac output, okay, is equal to heart rate times stroke volume. If you increase the heart rate, you increase the stroke volume, okay, you will increase your cardiac output. Take note, okay, in the med boards, even though this is the one that we all know, okay, there's another way to compute for cardiac output, and that is through what we call the Fick equation. So, okay na yung Fick equation na yan sa med boards ng physio, okay, cardiac output is equal to oxygen consumption, okay, over arteriovenous O2 difference. So we call this your Fick equation. Questions have been asked consistently for the past several boards na. Okay, yung Fick equation mo. Now, your heart, okay, can basically be divided into two. You actually have two hearts, your left heart and your right heart, okay? Cardiac output, okay, of your right heart, we call that your pulmonic blood flow. Okay. Cardiac output of the left heart, we call that your systemic blood flow. Okay. Now, ito yung rule. The cardiac output of the left heart should be equal to the cardiac output of the right heart. Okay? Na kung isipin mo, Doc, paano naging pantaya? Bakit ang cardiac output ng left heart parehas lang sa cardiac output ng right heart? Hindi po ba ang left ventricle ay mas makapal ang walls compared sa right ventricle? Ergo, dapat mas mataas yung stroke volume, mas mataas yung cardiac output sa left compared sa right. Hindi po ba dapat hindi sila equal? Well, you are correct. Okay? The left ventricular walls are thicker, okay, than the right ventricular wall. Okay, however, the aorta that follows the left ventricle has thicker walls compared to the pulmonary artery. Okay, so the aorta will provide higher resistance to blood flow compared to the pulmonary artery. So, ang left heart mo, net effect, yung left ventricle mo malakas mag-contract. Pero yung kailangan niyang labanan na resistance dito sa aorta, mataas din. Yung right ventricle mo, supot. Hindi masyadong malakas ang ventricular contraction ng right ventricle. Pero yung kailangan niyang i-overcome na resistance ng pulmonary artery, hindi rin naman ganun kataas. Mababa lang. That's why at the end of the day, the cardiac output of the left is equal to the cardiac output of the right heart. There are so many ways of stating this in the exam. Ang daming ways na pwedeng lituin yung mga estudyante. Pwede lang kayong tanungin, what is the percentage cardiac output of the left compared to the right? What's the percentage cardiac output of the right compared to the left? Well, the answer is 100%. They're supposed to be equal with one another. Okay, cardiac output of the left should be equal to the cardiac output of the right heart. Okay, next. So, let's take a look at this. What's the normal cardiac output value, Doc? So again, it will vary according to the reference that you read. Some reference will say the normal cardiac output at rest is 4.9, 5.3. Okay? So, physio teachers in the Philippines at rest, okay, cardiac output is approximately 5 liters per minute. If you have maximal heart rate, maximal cardiac output, okay, that 5 liters will increase to 20 liters per minute in a non-athlete. And for an athlete, from 5, it will increase to 30 liters per minute. Okay? Bakit mas mataas pag athlete? Well, athletes' hearts are larger. They have undergone hypertrophy secondary to their training. Classically, kapag athlete ka, your heart rate is lower, your stroke volume is higher. So this is at rest. So heart rate lower, stroke volume higher in an athlete at rest. They have the same cardiac output as non-athlete, 5 liters per minute. But the moment they achieve maximal heart rate, okay, compared to non-athletes, okay, dahil naturally mataas ang stroke volume nila, yung maximal heart rate parehas lang for both athletes and non-athletes. It will just depend on your age. So, you're going to expect much higher cardiac output for the athlete at maximal heart rate kapag nag-exercise sila. Okay? Now, let's discuss blood vessels. So, blood vessels, you have your arteries, arterioles, capillaries, and veins. Remember this dictum, okay? Blood and air will only flow from high pressure to low. Blood and air will only flow from high pressure to low. So, if blood and air will only flow from high pressure to low, trick question, saan mas mababa ang pressure? Mas mababa ba sa capillaries o mas mababa ang pressure sa veins? Saan mas mababa ang pressure? Capillaries or veins? So the correct answer to that is veins. Mas mababa ang pressure sa veins. Because blood is flowing from arteries to arterioles, capillaries, and veins. So if you want blood to flow from capillaries to veins, dapat mas mababa yung pressure sa veins mo. So we'll discuss that a little bit more later. For now, let's discuss the various types of blood vessels. Okay? First, arterioles. Arterioles are control conduits, meaning they can control blood flow. Okay? Your arterioles, okay, are the main determinants of two things. They will determine blood flow to the organ, and they will determine total peripheral resistance. Synonym. Total peripheral resistance is also called your systemic vascular resistance. So do not be surprised if that is utilized in some of your other handouts here in Top Notch. Okay? So I like arterioles. They're my favorite because they basically control blood flow to the organs. Okay? They are the ones that determine blood flow, okay, to your organs. So let's take a look. Okay? How will arterioles affect blood flow and total peripheral resistance? Arterioles, okay, arterioles can dilate or constrict. Arterioles can dilate at to great diameters. Arterioles can also constrict almost to the point of closure. So what will happen when arterioles vasodilate and what will happen when arterioles vasoconstrict? When arterioles vasodilate, okay, what will happen to blood flow to the organ? Will it increase or decrease? It will increase. Okay, there will be more blood going to the tissues if they vasodilate. But if arterioles vasodilate, what will happen to total peripheral resistance or systemic vascular resistance? Total peripheral resistance is the resistance to cardiac output. Okay, your arteries will follow the left ventricle. So if you have arterioles, okay, that follow those arteries, if the arterioles now will vasodilate, okay, we expect total peripheral resistance to go down. Okay? How about when arterioles vasoconstrict? When arterioles vasoconstrict, okay, blood flow to the tissue will decrease. Nag-vasoconstrict di less na yung pupunta sa tissues mo. However, when arterioles vasoconstrict, total peripheral resistance will increase. Okay? Now, let's take a look. Okay? Ohm's law states that blood flow is equal to change in pressure over resistance. Okay? Ohm's law is actually a law of physics for electricity. If you remember, the formula then in high school was current is equal to voltage over resistance. Current is equal to voltage over resistance. Applied to cardiodynamics, current is blood flow, okay? Voltage is change in pressure, pressure gradient, okay? Resistance is resistance. So blood flow is equal to change in pressure over resistance. Stated another way, this formula, blood flow to the entire human body is cardiac output. Pressure, that's blood pressure. Then resistance to cardiac output, that's TPR. So transmuted, okay, yung formula ng Ohm's law, we have this. This is probably familiar to you. This is the basis for that classic equation that most students know, are familiar with. Blood pressure is equal to cardiac output times total peripheral resistance. If cardiac output is equal to heart rate times stroke volume, so stated another way, blood pressure is equal to heart rate times stroke volume times TPR. Implication, when heart rate increases, tataas ang blood pressure. When stroke volume increases, tataas yung blood pressure. Okay? When arterioles constrict at tumaas ang TPR, blood pressure will also increase. Now, nice question. If you exercise, what do we expect to happen to these values? When you exercise, okay, the arterioles in your skeletal muscles will vasodilate to provide more oxygen, glucose to the starving muscles. So we expect that during exercise, total peripheral resistance will decrease. TPR is directly proportional to blood pressure. So do we expect to see a drop in blood pressure during exercise? No. So bakit hindi bababa yung blood pressure kahit yung TPR mo bumababa during exercise? The reason for that, of course, probably you've noticed it already, during exercise, both heart rate and stroke volume will increase. And when these two increase, okay, they will more than compensate for the drop in TPR. That's why your BP overall will increase during exercise. Okay, that's why bago ka mag-gym, if you enrolled for Fitness First, Gold's Gym, okay, they will get your history and they will probably take your probably test for your blood pressure because they know, okay, that during exercise sa gym nila, pwedeng tumaas yung BP mo. Baka mamaya dyan ka pa mag-MI, mag-stroke. So, kinukuha nila yan. Okay? Next. So, arterioles, blood pressure, okay? TPR, okay? Yan yung medyo noticeable dyan. Again, vasodilation. Take a look at what happens. Vasoconstriction. Take a look also at what happens. Okay? Next, arteries. Arteries and veins and arterioles will have three layers. From innermost to outermost, we have the tunica intima, tunica media, and tunica adventitia. The tunica intima, this is where you're going to find endothelial cells. Tunica intima. The tunica media, this is where you're going to find vascular smooth muscles, along with your adrenergic receptors. Your beta 2 for vasodilation, alpha 1 for vasoconstriction. And finally, your adventitia, this is where you're going to find, okay, connective tissue. Okay? Comparing arteries and veins, arteries are thicker, stiffer, okay? The pressure there is under high pressure. That's why we call the blood inside the stressed volume. While for veins, their walls are thinner. Their tunica media adventitia is thinner. Okay? We call them your capacitance vessels because most of your blood is actually found in your veins. It is a misconception that most of your blood is found in the arteries or capillaries. 64%, majority of your blood is actually found in the veins. That's why we call your veins the reservoir of blood. The reservoir of blood, your veins. Okay? Your veins compared to arteries are more compliant, more distensible, and have a higher capacitance. More compliant, okay? More distensible, have a higher capacitance because they have a thinner tunica media, a thinner tunica adventitia. Okay? Your veins will contain one-way valves to prevent backflow. Okay? Next, let's discuss capillaries. Okay, previous board exam question, your capillaries will have the largest total cross-sectional area. This is important because cross-sectional area is inversely proportional to blood flow velocity. That's why take note, okay? Capillaries will have the largest total cross-sectional area. It will ergo have the slowest blood flow velocity. This is engineered by God. May engineering reason yan. Why do you want a very slow blood flow velocity in the capillaries? To allow adequate time for gas exchange. Your capillaries is notable because it only has endothelial cells. So it only has basically a tunica intima. There's no tunica media, no tunica adventitia for capillaries. Ergo, kung wala kang tunica media, capillaries are not capable of vasodilation or vasoconstriction. Capillaries do not dilate, capillaries do not constrict. However, okay, before your capillaries, there are structures that we call meta-arterioles and precapillary sphincters. So what, Doc, if they have meta-arterioles and precapillary sphincters? Meta-arterioles have smooth muscles. Okay? And then if you have sphincters here, the implication basically of having these two structures is that you can have open or closed capillary beds. You probably heard about these terms before, open or closed capillary beds. What does it mean? One misconception is that we're utilizing all our capillaries all the time. No, guys. Most of our capillaries are actually closed, and they will only open when there is an increased demand for blood. So for example, the capillary beds in your skeletal muscles, usually, karamihan sa mga yan, closed. Then when you start exercising, they will open up to accommodate more blood, to give more oxygen and glucose to the tissues. So the concept of open or closed capillary beds, okay, that is done using, okay, those mechanisms, metaarterioles and precapillary sphincters. So after capillaries, okay, finally we have your lymph vessels. Lymph vessels are not blood vessels, of course. Okay? These lymph vessels will carry lymph. Okay? So, when you hear the term lymph vessels, lymphatic vessels, I want you to think of them as drainage canals. So, that's the main function of your lymph vessels. They are drainage canals. Okay? Just like canals, ano ba yung function ng canal? It prevents you from having flooding, right? Pinaprevent niya yung magbaha. So, basically, after the capillaries, you have your interstitial fluid here. Okay, so the interstitium is basically the area in between cells. So we have here these lymph vessels, okay, to prevent water from accumulating in the interstitial spaces. So they will act like drainage canals. Okay, they will return back water and some of the proteins back to your venous system, back to your circulatory system. Okay, so lymph vessels are drainage canals. They drain proteins and fluids from the interstitium. Specialized lymph vessels in the GI tract, okay, are called lacteals. These lacteals, lymph vessels in the GI tract, they carry chylomicrons. So chylomicrons is a way to transport triglyceride, transport fat, okay, from the small intestines going to the blood. So lacteals will be there, okay, to transport these chylomicrons, okay, and eventually it will find itself back to the blood. Lymph vessels will also contain lymph nodes. That's why the lymph vessels are also involved in immunity and cancer. Okay, let's answer some of these questions. They've been asked before in the med boards. They're taken either verbatim or in a slightly modified format from Physio BRS. The greatest pressure decrease in the circulation occurs across the arterioles because they have the greatest resistance. Just like what I have told you, okay, they're the main determinants of total peripheral resistance or TPR. Next, very interesting question. At which size is systolic pressure the highest? So you'll probably think, Doc, di ba dapat aorta yung sagot dyan? Bakit naging renal artery? Surprise, surprise, this is correct. There's actually a picture from Guyton that proves this, okay? Mas mataas ang pressure sa branches ng aorta kaysa sa aorta itself. Among the things listed here, the one that is a branch of the aorta is this one. the renal artery. Okay? Ano nangyari dyan, Doc? Okay? Halimbawa kasi, ito yung aorta mo. Okay? Tapos, ito yung immediate branch ng aorta. So, that can be your renal artery or any other artery can be an answer here as long as it's a direct branch of the aorta. Okay? Blood in the aorta is of course flowing at high pressure. Okay? However, when you have these branch points, the moment magkailangan niya mag-sudden turn, papunta dyan sa mga branching points na yan, sa mga branches ng aorta, tatamaan niya itong part na to, okay, nung branch mo. So at the branching points, tatamaan niya yung first part nung artery. Okay? So kapag tumama yan dyan, tataas slightly yung pressure even greater than the aorta. Okay? Imagine mo your analogy. Imagine mo you're driving a car at 300 kilometers per hour in EDSA. Then you make a sudden left turn or sudden right turn. Tatama ka dun sa gutter. So obviously, yung pagtama mo sa gutter, mas malakas yung pressure na makikreate mo from that impact. Okay? So high speed blood making a sharp turn, boom. Okay? Tataas yung pressure dito slightly. So what is the explanation? Bakit mas mataas ang pressure sa branching points kaysa sa aorta itself? It's blood making salpak-salpak the walls of the branches near the aorta. Okay? This is our circulatory system. It was called circulatory system because you basically just move blood all around. You have a total of 5 liters of blood in you. Okay? So, super basic. Okay? The heart is centered dito sa circulatory system. Four chambers, 2 atria, 2 ventricles. 4 valves. Dalawang AV valve, tricuspid on the right, mitral on the left. Dalawang semilunar valves, pulmonic on the right, aortic on the left. Okay? From here, we have the aorta, then its branches, okay? Then going to your arterioles, then going to your capillary beds, then from here to the veins, okay? Then all the veins will eventually find itself in the superior inferior vena cava. The superior and inferior vena cava will then drain into the right atrium. All blood will eventually drain into the right atrium. Ergo, okay, because all blood will eventually drain into the right atrium, okay, right atrial pressure now, okay, will be synonymous with the term central venous pressure. You've heard of that term before, central venous pressure. It was called central venous pressure because the right atrium, for all intents and purposes, it's considered the central vein of the circulatory system because all veins, okay, via the SVC, IVC will eventually drain into the right atrium. Pressure is lowest here at the right atrium. Okay, the pressure there is just around 0 to 4 millimeters mercury. Then from there, it will find itself to the right ventricle, magkocontract yan. Then to the pulmonary artery, pulmonary arterioles, pulmonary capillaries. Pulmonary capillaries, site of gas exchange. From here, it will now go to the pulmonary vein and then back to the left heart via the left atrium. Pulmonary artery, umbilical artery are the only arteries that carry the oxygenated blood. Pulmonary vein and umbilical vein are the only veins that carry oxygenated blood. Okay? Formulas. We gave you a poster, a top-notch poster containing formulas for physiology. Okay? Doc, marami po bang equation sa board exams natin sa physiology? We don't know. We don't have any leakage. You cannot be completely sure. But in the past, there have been batches na ang daming physio equations. Most of the time, okay, isa, dalawa. Okay, but there are batches na madami. As many as, 10, 15 equations. So, it's better to be prepared for the scenario na maraming equations kaysa wala. The equations I'm going to give to you, just like what I've told you previously, okay, they've all been asked or utilized before in the med boards. There are a lot more equations that I didn't include there. Equations coming from Guyton na Bern. So kapag nandyan sa handout nyo, it means importante yan. Hindi yan decorations. Okay? Place it on your poster. So kahit paano magkaroon kayo ng familiarity. Okay? Ma-memorize nyo yan close to the exam. Okay? Let's discuss some of these formulas. previous board exam questions. First is blood flow velocity. Velocity. Okay? Blood flow velocity. Blood flow is fastest in the aorta and slowest in the capillaries. There's a formula for that. Must know, nagamit itong formula na to in one of the questions. Velocity is equal to blood flow Q over cross-sectional area. Ergo, the higher the total cross-sectional area A, the lower the blood flow velocity. That's why capillaries, because of their high total cross-sectional area, capillaries will have the slowest blood flow velocity. Okay? Blood flow is directly proportional to the pressure difference, inversely proportional to resistance. Based on Ohm's law, again, blood flow is equal to change in pressure over resistance. Okay? This resistance, the R that you see here, we can utilize in terms of resistance to blood flow. We can utilize in terms of what we call the law of Poiseuille. Okay? So the law of Poiseuille, social doc, French. The law of Poiseuille states that resistance is equal to 8 times viscosity N times length of the vessel away from the heart L over pi times the radius of the vessel raised to the fourth power. Okay, let's take it one by one. N. N is viscosity of blood. Okay? Viscosity of blood is not synonymous with the term resistance to blood. Viscosity, ang hirap i-define in physics resistance to rolling, parang ganon, of blood. Viscosity is mainly determined by hematocrit in blood. Okay? Hematocrit is the percentage of cells in whole blood. So the more viscous you are, the higher the resistance for it to roll. Okay? And that is caused by high percentage of cells in whole blood, a high hematocrit. Okay? So that's one. If you have higher viscosity, you will have higher resistance to blood flow. L is length of the vessel away from the heart. Okay? Guys, yung L na yan is directly proportional to resistance. So, ano ibig sabihin noon? This is the reason why you have a DM foot and not a DM armpit. Why you have a DM foot and not a DM chest. Okay? If you are a blood vessel in the big toe, the L is very high because you're very far away from the heart. So, if you are a vessel in the big toe, okay, L is very large. Resistance is also very high. And ergo, based on Ohm's law, cardiac output, okay, or blood flow to the entire organ is low. Okay? So, ano implication nito? Okay? So, kung blood vessel ka doon sa big toe, mataas yung L, mataas yung resistance, mababa relatively yung blood flow, kapag nagkaroon ng sugat dyan at nagkaroon niya ng infection, may bacteria na pumasok dyan, fiesta for bacteria dahil wala siyang kaaway. Okay? Mababa yung blood flow mo eh. So, paano pupunta dyan yung mga cells mo that can kill that bacteria? Fiesta sila. Kaya nga mag-prone na magkaroon ng DM foot at hindi DM armpit. Okay? Next, the radius of the vessel raised to the fourth power. So, this is probably the most important among all of the factors there. Okay? If this is my blood vessel diameter, and then ginawa ko lang because of atherosclerosis, naging kalahati siya. Okay, sakto. Pag ganyan. Ito yung blood vessel diameter ko, and then because of atherosclerosis, naging kalahati na lang siya. So what will happen if my radius now, okay, becomes half of its normal value? What will happen to my resistance? And more importantly, what will happen to my blood flow? If that happens, my resistance will be, okay, 8NL over pi times 1/2 raised to the fourth power. If you do the mathematics for this is 1/2 times 1/2 times 1/2 times 1/2. Your resistance will actually increase by 16 times its normal value. And because blood flow is inversely proportional to resistance, it means now that my blood flow will be 1/16 its normal value. So, naging 1/16 its normal value even though, okay, ang radius ko ginawa ko lang kalahati. So, several magnitudes higher ang nangyayari dyan. So, very important, okay, when you decrease by half yung radius ng vessel mo, okay, your resistance will increase by not 2 times, by 16 times. and your blood flow value will now be 1/16 its original value. So, malaki yung changes with that R. Okay, malaki ang changes with the R dahil raised to the 4th power siya. Okay? So, previous board exam question, several times na rin natatanong across batches, 53-year-old, blah, 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 50% narrowing, blah, blah, blah. So, what's the expected change in blood flow to the stenotic artery? Decrease to 1/16. I used to joke around with the students. Sabi ko, pag nakakita kayo sa board exams because they just repeat the questions from Physio BRS, or they just modify them so slightly, the choices are retained, the correct answer is still retained. Pag nakakita kayo kunwari ng 53, basta ang sagot 1/16. I used to joke it with them. Okay? Pag malapit na siguro boards, pwede nyo gawin yung pinagbabawal na technique na yan. Okay? Pero mas importante is for you to understand the basis. It's based on the law of Poiseuille and based on Ohm's law. A combination. Remember sa Ohm's law, may R. Yung R na yan ay expound dito sa law of Poiseuille mo. Okay? Next. Laminar and turbulent blood flow. When you say laminar blood flow, it means straight line, streamline blood flow, where blood flow velocity is fastest at the center and where blood flow velocity is lowest near the walls because of the resistance. Laminar blood flow is normal, and this is the one that we desire. Turbulent blood flow, as the name implies, is haphazard, irregular blood flow. This is what we don't want, irregular, disorderly blood flow. Your turbulent blood flow, okay, its probability is predicted by what we call your Reynolds number. Reynolds number is an equation. Take a look, okay? If your Reynolds number is high, okay, there's a high probability that you're going to see turbulent blood flow. So what's your Reynolds number? Reynolds number is equal to, okay, density of blood P times diameter times velocity of blood flow over viscosity of blood flow N. Okay? Remember, viscosity is again your hematocrit. Okay? The percentage of cells in whole blood. So, saan ka ngayon mas prone magkaroon ng turbulent blood flow? Sa a patient with polycythemia or a patient with anemia? Okay? So, mas prone ka magkaroon ng turbulent blood flow in a patient with anemia. Bakit? Mathematics. Pag meron kang anemia, mababa ang viscosity. And because viscosity is inversely proportional to Reynolds, Reynolds number now will be high. Okay? That's why anemia will predispose you to having turbulent blood flow. Okay? Polycythemia will predispose you to increased resistance. Okay? Increased resistance to blood flow based on the Reynolds number, the one we previously discussed. Okay? And it will give you lower blood flow. Lower Q. Okay? So, pag sinabi, saan ka makakita ng turbulent blood flow? Anemia. Saan ka makakita ng decreased blood flow? Okay? Polycythemia. So, be careful. Shear stress, March 2023, is the tangential force of blood flowing in the blood vessel endothelial surface. High shear stress is seen in laminar blood flow. Okay. Compliance, capacitance, distensibility. Not synonymous terms, capacitance, compliance, distensibility, but directly proportional. Okay? Capacitance is actually a formula, volume over pressure. Change in volume over pressure. Okay? What does it mean to be compliant? What does it mean to have a higher capacitance? What does it mean to be distensible? Ibig sabihin nito, kahit konting pressure lang, malaki na yung change mo sa volume, ikaw ay compliant, distensible, have a higher capacitance. A plastic toy balloon, when you blow air, konting hangin lang, nag-change na siya ng volume, di ba? Tumataas na dramatically yung volume mo. Pero konti lang yung pressure na nilagay mo. So siya ay compliant, distensible. Compare that with rubber tires ng kotse. Yung rubber tires ng kotse, hipan mo, ikaw mag-isa, hindi mag-change ng volume kaagad. Okay? So, hindi siya ganun ka-compliant compared to plastic toy balloons. Okay? Capacitance, compliance, and distensibility of veins are greater compared to capillaries. That's why most of your blood will be contained in your veins rather than your capillaries. Okay? Next, systolic diastolic pressure. When you hear the term systole means ventricular contraction. Diastole means ventricular relaxation. Those are the proper terms, by the way, and the proper pronunciation. Systole, diastole. However, for my lectures, forgive me, but if for pronouncing it systole, diastole, it's simply much faster. Okay? Highest arterial blood pressure is systolic pressure. The pressure in the vessel when the ventricles are contracting. Lowest arterial blood pressure is diastolic pressure. The difference between systolic and diastolic pressures is called pulse pressure. So what is the normal pulse pressure now? Okay? If the normal BP is 120 over 80, the normal pulse pressure will therefore be 120 minus 80 or 40. Okay? There's another way for computing for pulse pressure, and this is the one more important. Pulse pressure is equal to stroke volume over arterial compliance. The greater the stroke volume, the greater the pulse pressure. The lower the arterial compliance, the higher the pulse pressure. Okay? Previous board exam question. When you grow older, what happens to arterial compliance and what happens to pulse pressure? As you grow older, arterial compliance will decrease. Why, Doc? Because of what we call arteriolosclerosis. The stiffening of the arteries as we age secondary to calcium deposits. Okay? There are very few inevitable things in life. I tell my students, what are the inevitable things in life? Inevitable things in life. Death, taxes, traffic, presbyopia, and arteriolosclerosis. Everyone will have presbyopia around age 40 and above. Okay, the loss of accommodation as you grow older, secondary to a stiffening lens. And then, as you grow older, you will also experience arteriolosclerosis, secondary to stiffening of the blood vessels from calcium deposits. Okay? As you grow older, arteriolosclerosis happens, arterial compliance decreases, ergo pulse pressure increases. A previous board exam question, and a good board exam question. I think they got that also from Physio BRS. Okay? The main determinant of pulse pressure is stroke volume. Formula for MAP. MAP is mean arterial pressure. The formula is 2/3 diastolic pressure plus 1/3 systolic pressure. Or, alternative formula, diastole plus 1/3 pulse pressure. Okay? Next, okay? Ejection fraction. The formula for ejection fraction is stroke volume over end diastolic volume. Normal value of ejection fraction, 55%. Okay? So what is ejection fraction? If this is your heart and the ventricles contract, okay, it is a misconception that all the blood initially contained will go to your aorta. No. Okay? The blood before the ventricles contract, the blood in the left ventricle before it contracts is called end diastolic volume. The amount of blood that will actually be pumped into the aorta per heartbeat is called stroke volume. So the percentage of blood in the ventricles before it contracts, the percentage that will actually be ejected into the aorta is what we call your ejection fraction. And the normal ejection fraction is just 55%. Meaning if you have 100 ml of blood as your end diastolic volume, only 55 ml will be your stroke volume. Only 55 ml will be ejected. The other 45 ml will remain in the left ventricle. Okay? So that is your EF, ejection fraction. Okay? A marker for heart function. Normal artery pressures listed here. It's a range. That's why hindi siya definite na. It's 15 to 25 over 8 to 10. Normal ratio of systemic to pulmonary pressure is 3:1. Measured using Swan-Ganz catheter, estimates left atrial pressure. This is your PCWP. Pulmonary capillary wedge pressure. Now, these are the causes of widened or increased pulse pressure, narrow or decreased pulse pressure. Unfortunately, there's no mnemonic for that. No story, no analogy that will help you. Okay? But, okay, right now, you probably, guys, one of the things that you have to develop for the next 2.5 months of preparation for the boards, you need to develop your sense of smell. Kung lalabas ba o hindi yung isang concept or principle sa exam. Ito, parang maaamoy mo na eh. Pwede ba itong lumabas sa exam? Which of the following can cause an increase or decrease in pulse pressure? Yes. Ano mo na. Based dun sa mga practice test natin, practice test na sinagot ninyo. Okay? Based dun sa, put yourself in the perspective of the examiner. Can they ask questions here? Yes, it is entirely possible. What should you do? This table, ang problema rito, if you try and memorize this now, probably, pagpupo mo pa lang for dinner later, makakalimutan mo na siya. Madali siyang makalimutan eh. Walang story. Parang nagme-memorize ng cellphone numbers ng mga kaklase mo eh. So, anong gagawin natin, Doc? If I memorize this now, it will take me 2 hours and then after some time, ang bilis lang din niya makalimutan. Nasayang yung oras ko. So, for these tables na posibleng lumabas sa boards, pero alam mo naman na hindi mo talaga usually magagamit for general practice. It's not as relevant as the other things in physiology. Ang gimmick dyan, guys, is either to place an asterisk in your handouts. Okay? Or take a picture, a screen cap, and place it doon sa cellphone mo. Okay? Kahit yan, ito lang. Yung mga ganyan lang, yung particular table na yan. Okay? And make it part of what we call the last minute notebook. Ano yan? Yung mga parts na yan, yung mga may asterisk, may star, lalagay mo sa handouts or sa post-it. Probably post-it is best. And then, hindi mo siya i-memorize ngayon. Titingnan mo lang siya 30 minutes to 60 minutes bago mag-physio exam. Bakit ganun ang strategy daw? Okay? If you try and memorize this now, you will easily forget it. You know it can be asked in the med boards. So, most efficient thing to do is to store it in your short-term memory. Okay, 30 minutes to 60 minutes before exam, take a look at it. Maalala ko ba, Doc? Yes, you will probably be able to remember this. Paano kayo maalala, Doc, kung 30 to 60 minutes na lang, exam na? Okay, out of sheer fear, maalala mo yan, trust me. So close to the med boards. Okay, your heart is pumped, sympathetic stimulation, everything. Okay, maaalala mo yan. At kung hindi mo man maalala, there's at least familiarity. Kasi very short lang eh. 30 minutes ago lang, 60 minutes ago eh. So, place this in your last minute notebook. May mga iba pang tables na ganyan. Yung mga tipong hindi magagamit naman talaga sa clinical practice. So, I couldn't recommend na i-memorize na ngayon. Matagal siya ma-memorize, madaling makalimutan, pero posible lumabas sa boards. Okay? The other table there, for example, is yung sa interleukins. So, I'll give you tips. Okay? Paano tandaan yan? Ano yung mga tinanong before. But for now, place an asterisk or star. Place it in your post-its, for example. Last minute notebook. Okay? Next, ECG. Doc, will we be given ECG strips, chest x-ray, pictures, and be asked to interpret? The answer is no. For the past 17 years ng med boards, they've only utilized pictures just once. I think it was a graph or PrevMed several years back. Other than that, they've never utilized pictures. No ECG strip, no X-ray findings. I think they're worried na baka hindi maganda yung quality ng picture na gagamitin nila. That's why they avoid doing that. Okay? However, they can give you findings, written findings from the ECG and ask you to interpret in terms of a case. Ngayon, buti na lang, in terms of the med boards, mababaw lang ang nire-require. Okay? Hindi yung mga Wolf Parkinson White, walang mga ganun na hardcore. Okay? Mababaw lang. Atrial depolarization, P-wave. Ventricular depolarization, QRS. Ventricular repolarization, T-wave. Ganun lang. Okay? Dagdagan pa natin ng konti. Pampasaya ng buhay. Intervals. Okay? One heartbeat can basically be divided into two portions. The PR interval and the QT interval. Everything that happens to your atrium is the PR interval. Everything that happens to your ventricles, QT interval. So this QT interval will include ventricular depolarization and repolarization. Okay? Next. When you hear the term segments, PR segment, ST segment, think of the number 0. Segment, 0. Okay? Your segments are isoelectric portions of the ECG, 0 millivolts. Okay? Your ST segment, previous board exam question, okay, it correlates with phase 2 of the ventricular action potential. Phase 2, plateau, calcium 2 plus, ST segment. Okay? Next. So, heart blocks are another favorite in the med boards. Okay, you need to be able to know the pathophysiology, manifestations of first degree, second degree, and third degree AV block. So in first degree AV block, there is prolongation of the PR interval. Okay? Second degree AV block, there's a drop beat. Okay? And two subtypes, Mobitz 1 and Mobitz 2. Mobitz 1, there is prolongation, okay, of the PR interval before the drop beat. Okay? Mobitz 2, there is no prolongation of the PR interval. Constant or equal ang mga PR intervals mo before the drop beat. So, Mobitz 1, Mobitz 2, natanong na yan sa exam. Mnemonic, Mobitz 1, think of an up arrow. There is prolongation of the PR interval before the drop beat. Mobitz 2, the column na Roman number 2. So, as you can see in the Roman number 2, equal yung heights nila. So, there is constant PR interval, no prolongation, okay, before the drop beat. Third degree AV block is what we call atrioventricular dissociation. Ano ibig sabihin nun? The atrium and ventricles have their own respective rhythms. Okay, this is the one, third degree AV block, is the one associated with fainting and syncope, a previous board exam question. So, there's a mnemonic for this, first degree, second degree, third degree AV block. So, parang ano yan? Away ng mga lovers. First degree AV block, okay, nagiging malayo ang feeling nyo sa isa't isa. There's prolongation of the PR interval. Second degree AV block, okay, you now drop dates and meetings. So, dati malayo lang yung feeling nyo. Ngayon, it will manifest na. Kaya na makipag-date. And third degree AV block is the worst type. Hiwalayo na talaga. Completely divorced na kayo and you're living separate lives. First degree, second degree, third degree AV block. Okay? Hyperkalemia, observe the T wave. Okay? The flatter the T wave, the lower the plasma potassium level. You're going to see hypokalemia. The taller the T wave, okay, the higher the plasma potassium. You're going to see hyperkalemia. Okay? Prolonged QT interval is hypocalcemia. Shortened QT interval is hypercalcemia. Okay? The cardiac action potential we have discussed earlier. Okay? So we have once again, ano ba yung mga cardiac action potential? We have your phase 0, 1, 2, 3, 4. 0, 1, 2, 3, 4. Depolarization caused by sodium influx, partial repolarization, potassium efflux, phase 2. Okay, plateau, calcium influx being equal to potassium efflux. Phase 3 is complete repolarization, potassium efflux alone. Phase 4 is your RMP. RMP in the ventricles, in the ventricular muscles, is negative 90 millivolts. Pacemakers. So, pacemakers are capable of what we call self-excitation, okay, or autorhythmicity. The master pacemaker is the SA node, okay. It exerts an overdrive suppression of the other pacemakers. The others listed here are what we call your latent pacemakers. AV node, bundle of His, Purkinje, latent pacemakers. So, bakit nga ba, okay, ang SA node ang master pacemaker? Bakit ang AV node, bundle of His, Purkinje, hindi sila yung master? It has something to do with this. The SA node, the duration of its action potential will be like this. Compare that, for example, with the AV node. Ganito. Bundle of His, Purkinje. Ganito. So, ang ibig sabihin nito, shorter yung duration ng SA node action potential. So, anong ibig sabihin nun? Halimbawa, ako si AV node. Ako yung vice president. Gusto kong mag-self-excite. So, halimbawa, dito na ako si AV node. Gusto kong mag-excite. Ulul, mag-excite ka na. Sige. Bundle of His, Purkinje, gusto kong mag-excite. Ulul, mag-excite ka na. So, what I mean by this, even before they are able to self-excite, they're already previously stimulated by the prior pacemaker. Okay? So in this case, the one with the shortest duration is the SA node. Therefore, because it will have the shortest duration, it will have the highest intrinsic rhythm or highest intrinsic firing rate. Okay? Take a look. Intrinsic rate, highest for the SA node. What happens now if the SA node dies? For example, you have a myocardial infarction, destroyed the cardiac muscles in the atrium, right atrium, where the SA node is found. Well, pag namatay president, the vice president will take over. So kung namatay yung SA node, the AV node will take over. What do you expect to happen pag nag-AV node now becomes your master pacemaker? Will you have an increase or the decrease in heart rate? You're going to expect a decrease in heart rate dahil ang intrinsic firing rate ng AV node is mas mababa compared sa SA node. Okay? So, SA node is the main determinant of heart rate. However, AV node, because it has the slowest conduction velocity in the conduction pathway, the AV node is the one that will determine conduction velocity. In a series of steps, the slowest step will be the one to determine, okay, when the entire pathway will be over. So in terms of this conduction pathway from SA node all the way to the Purkinje fibers, the slowest portion, which in this case is AV node, will be the one to determine ultimately conduction velocity. Okay? Purkinje fibers will have the fastest conduction velocity. AV node will have the slowest conduction velocity. SA node action potential is once again phase 4, 0, and 3. Sodium influx, calcium influx, okay, potassium efflux. Phase 4, 0, 3. Okay? Next. Inolusicronodromotrophic effect. Inotrophic effect is changes in contractility. So, inotropes will affect stroke volume. Okay? Example of positive inotrophic agent, we have digoxin. Lucitrophic effect affects the rate of relaxation. Chronotrophic, chrono, affects heart rate. So, it will affect the SA node. Dromotrophic effect, okay, affects conduction velocity. So, it will affect your AV node. So, in pharma, you're going to see positive inotrophic agents, negative inotrophic agents, positive chronotrophic agents, negative chronotrophic agents. Positive inotrophic agent, okay, digoxin. Name me a positive chronotrophic agent that you've ingested this morning. What? Coffee? Okay. Caffeine? Yes. Methamphetamines? Pwede din. Hopefully, you didn't ingest that. Caffeine lang. So, positive chronotrophic agent. Okay. Beta-1 stimulation of the heart will cause a positive inotrophic, lucitrophic, chronotrophic effect. So, your heart will now contract in a stronger fashion, briefer contraction, more frequent contraction. Okay? Autonomic effects on heart and blood vessels. Okay? The SIMPA will again have an effect on both the blood and both the heart and the blood vessels. So in the heart, it will increase the heart rate, conduction velocity, and stroke volume, okay, via beta 1. In the arterioles of the skin, iba-iba, skin and arterioles, plankton arterioles and veins, vasoconstriction will occur. Skeletal muscles, there will be vasodilation. So you're shunting blood to the muscles during exercise or during a fight or flight state. Okay, pag nano yung SIMPA. Para will decrease the heart rate, okay, decrease the conduction velocity, and atrial contractility via M2. It has no direct effect on stroke volume. Okay? No direct effect on stroke volume kasi walang parasympathetic innervation ng cardiac ventricles. It also has little to no effect on blood vessels kasi halos walang parasympathetic innervation ang blood vessels mo rin. Okay? Next. Preload. May preload sa skeletal muscle, may postload, may afterload din sa skeletal muscle. Applied to the ventricles, cardiac preload is your end diastolic volume, the volume of blood in the ventricles before it contracts. End diastolic volume is basically synonymous with pre-systolic volume. It's just the volume of blood in the ventricles before it contracts. So that is your cardiac preload, your left ventricular EDV. Rule, when the preload increases, cardiac output will also increase from the increase in stroke volume. Cardiac afterload, okay, refers to the aortic or pulmonary artery pressure. Rule, if you have an increase in afterload, it will decrease cardiac output because of the increased resistance. Okay, so based on Ohm's law, increased resistance. So very interesting, Doc. Load is load. Pabigat, di ba? So, bakit pag preload, pag left ventricular and diastolic volume, bakit tataas ang cardiac output ko? Hindi po ba dapat bababa? The reason for that is what we call Frank-Starling mechanism. Frank-Starling mechanism, I nicknamed it the rubber band effect. Ano ibig sabihin, Doc? Ba't nyo binigyan ng nickname niya na rubber band effect? Ang rubber band, if I stretch it and I let it go, there will be a snap. Okay? Because of its elasticity. That same rubber band, if I extend it even more, as long as it's not beyond the point where it will break, if I stretch it even more and I let it go, wabak! Mas malaki ang bounce back niya. So, ganun din ang nangyayari ngayon sa cardiac muscles mo. Your actin tropomyosin, okay, they are interspersed with one another, right? Your actin myosin. If you increase your left ventricular and diastolic volume, if you increase your cardiac preload, you will basically stretch your sarcomeres. And like a rubber band, when stretched, those sarcomeres now, when they contract, there will be greater number of cross-bridge cycles, and you will basically have, okay, increased stroke volume and increased cardiac output. Please be careful. There's a lot of ways of stating the Frank-Starling mechanism, and you might not even recognize them in the case. Ma-recognize mo lang siya pag nagtuturo ka na, tapos nakita mo, they're asking about Frank-Starling. So, pag tumaas ang venous return, take a look at the sequence. Tumaas ang venous return, tataas din ang end diastolic volume. The blood that goes to the right heart will eventually go sa left. So, when you have an increase in venous return, okay, tataas eventually ang end diastolic volume, mas stretch yung sarcomeres, greater force of contraction, greater number of cross-bridge cycles formed, increased stroke volume, increased cardiac output. Okay? So that is your FSM. An increase in the preload, an increase in your end diastolic volume, okay, will increase your cardiac output via an increase in stroke volume. Bainbridge, very nice. The same increase in venous return, okay, will stimulate cardiopulmonary baroreceptors to increase heart rate and increase your cardiac output. Okay? Earlier, I told you what is the sole purpose of the heart. The sole purpose of the heart is to match the venous return with the cardiac output. So how will that happen? It will happen now via two mechanisms, the Frank-Starling mechanism and your Bainbridge reflex. Okay? If cardiac output is equal to heart rate times stroke volume, if venous return increases, okay, stroke volume will increase via Frank-Starling mechanism. If venous return increases, heart rate will increase via the Bainbridge reflex. Both of these will therefore increase your cardiac output. Okay? Stroke volume, normal value is approximately 70 ml. Ejection fraction, normal value is approximately 55%. Fick equation, the one I was mentioning earlier, huwag nyo makakalimutan kasi yung cardiac output equals heart rate times stroke volume, hindi tinatanong sa boards. Ang tinatanong si Fick. May fetish for Fick. Okay, sa med boards. Cardiac output is equal to oxygen consumption over AVO2 difference. Arterio-venous O2 difference. Remember that formula. Okay? Take a look at the examples from Physio BRS if I included in your Physio handout. So, Frank-Starling, Bainbridge reflex. Let's discuss the cardiac cycle. The cardiac cycle tells you what happens in a single heartbeat. It will relate several things together. Okay? Your heart sounds, the ECG. Okay? It will relate the heart sounds, the ECG. Okay? The ventricular volume and pressure curves, the atrial pressure curve, and the aortic pressure curve. So you are now looking at what we call your Wieger diagram. A textbook or a review book in physiology is not legit Kung walang Wigger diagram, it's what makes physio. Okay, ang Wigger diagram mo. Classic yan. The original Wigger diagram actually was much simpler than this. Subsequent physiology teachers and authors merely modified the original Wigger diagram. So, in the Wigger diagram, the x-axis is basically time, while the y-axis is volume or pressure. It will tell you, okay, in a single heartbeat, what will happen, okay, in terms of this 6. Whenever I discuss Wigger diagram to my first year medical students, they always tell me, Doc, it's complicated, nakakatakot, it's complex. Okay? I firmly believe that nothing in medicine is truly complicated. Okay? Everything that seems complicated or complex can be broken down into smaller pieces that you can understand, and then later on you just need to integrate those pieces together. So let's break down these pieces. Your Wigger diagram, okay, is made up of 6 components: ECG, heart sounds, the one in blue, ventricular volume curve, the one in red, ventricular pressure curve, then these dashed lines are atrial pressure curve, aortic pressure curve. We relate the 6 in terms of what we call the 7 phases of the cardiac cycle. Those phases are atrial contraction, isovolumic contraction, rapid and reduced ejection, isovolumic relaxation, rapid and reduced filling. Let's break it down. Okay? First, the individual components. Okay? We have here heart sounds. So heart sounds, we have your first heart sound, second heart sound. The first heart sound is caused by the closure of your AV valves, your mitral and tricuspid. So this is your first heart sound caused by the closure of your AV valves. The second heart sound is caused by the closure of your semilunar valves, your aortic and pulmonic valves. Okay? ECG, mababaw lang. What do you need to remember? Atrial depolarization is P wave. Okay, sorry. Atrial depolarization, okay, is P wave. QRS is ventricular depolarization. T wave is ventricular repolarization. Okay? Ventricular volume curve, the one in blue. What should you remember? Okay? During systole, during diastole, okay, ventricular volume is increasing. During systole, ventricular volume is decreasing. Okay? And during what we call the isovolumic portions, isovolumic contraction, and isovolumic relaxation, ventricular volume remains the same. So in general, your ventricular volume increases during diastole. Makes sense. That's ventricular relaxation, ventricular filling. Ventricular volume decreases during systole. Makes sense. That's ventricular contraction, ejection. And then ventricular volume will remain the same during isovolumic periods. Isovolumic contraction, isovolumic relaxation. Okay? Next, the ventricular pressure curve, the one in red. In general, ventricular pressure is high during systole. Ventricular pressure is low during diastole. Okay? Next, the atrial pressure curve. The atrial pressure curve in comparison with aortic, okay, the atrial pressure curve is very low, anywhere from 0 to 4 millimeters mercury. Contrast that with aortic pressure curve. Aortic pressure is anywhere between 80 to 120. So in the atrial pressure curve, it's usually very low, okay? And you're only going to see 3 peaks, 3 instances wherein atrial pressure will be high, relatively high. Okay, so atrial pressure peaks, okay, will include your A wave, C wave, and V wave. Okay? Let me give you some mnemonics to remember them. So kapag may A wave, C wave, V wave, tumataas slightly yung atrial pressure. Mnemonics: A for atrial contraction. C for contraction of ventricles. And V for venous blood going back to the atrium. Let's see if it makes sense. Atrial contraction. When the atrium contracts, okay, when the atrium contracts, atrial pressure will increase. Yes, it makes sense. C, Contraction of the ventricles. Doc, when the ventricles contract, the atrial pressure will also increase? Also yes. Why, Doc? When the ventricles contract, the AV valves are pushed backward. The mitral tricuspid valves are pushed backward. There will be a decrease in the chamber size of the atrium. Same amount of blood, but decreased chamber size, that will manifest as a C wave, contraction of the ventricles. Okay? Now, I've based this on Guyton and Hall, this Wigger diagram. I'm well aware na, Doc, bakit yung C wave dito sa Physio-BRS, medyo nandito siya. Wala siya dito sa isovolumic contraction phase. It should be, mas tama yung nandun sa Guyton, sa Burn, it should be here, in the isovolumic contraction phase, yung C wave mo. Okay? V wave is for venous blood going back to the atrium. Okay? Does it make sense that when venous blood goes to the atrium, filling the atrium with blood, okay, that atrial pressure will increase? Of course. Okay, so that will manifest as your V wave. So A wave, C wave, and then V wave. Okay? Next, the aortic pressure curve. Aortic pressure is generally high during systole, during ventricular ejection. Okay? Aortic pressure becomes lower, it decreases during diastole. Okay? Because of ejection. Now, there is a portion here, okay, wherein there is a slight and transient increase in aortic pressure. It happens during isovolumic relaxation. So this slight and transient increase in aortic pressure is what we call your incisura or dicarotid notch. Board relevant. Your incisura or dicarotid notch. Ano nangyari, Doc, during the incisura or dicarotid notch? Okay? It happens during isovolumic relaxation. Slight and transient increase in aortic pressure. What happens? Okay? Isovolumic relaxation is basically the first part of diastole. When the ventricles begin to relax, blood in the aorta will try and go back to the ventricles. They are only stopped, okay, by your aortic valve. Nangyari, blood in the aorta tries to go back, boom! Sasalpak siya doon sa aortic valve, contributing to your second heart sound. At the same time, sasalpak siya sa walls ng aorta near the aortic valve. Pag salpak niya sa walls ng aorta near the aortic valve, boom! That will manifest as a slight and transient increase in aortic pressure. That will now manifest as your incisura or dicarotid notch. Analogy, imagine meron kang kotse and then nagbabaking ka. Pag backing mo, tinamaan mo yung dingding sa likod. Ganun nangyari dun sa dicarotid notch incisura. When blood in the aorta tries to go back to the ventricles, what happened? It made salpak-salpak the walls of your aorta near the aortic valve. Okay, causing a slight and transient increase in aortic pressure that we now call your incisura or dicarotid notch. So those are the 6 components, okay, of your Wigger diagram. Let's now talk about the phases. Okay, we have 7 phases. Atrial contraction, okay, isovolumic contraction, rapid and reduced ejection, isovolumic relaxation, rapid and reduced filling. So pagkatapos ng isovolumic, merong rapid and reduced phases. Isovolumic contraction, rapid and reduced ejection. Isovolumic relaxation, rapid and reduced filling. Okay? Let's talk about it one by one. Ano daw ang nangyayari? It will always start with the ECG, ang cardiac cycle natin. In the beginning, there was a P wave. Okay? P wave is atrial depolarization. Does it make sense that after the atrium depolarize, that there will be atrial contraction? Yes. So the P wave will precede, okay, atrial contraction. This period is your atrial contraction or atrial systole. So what happens when you have atrial contraction? When you have atrial contraction preceded by P wave, you're going to see, okay, your A wave in the atrial pressure curve. It makes sense. A wave is atrial contraction. You're also going to have, okay, an increase in ventricular pressure and an increase in your atrial pressure. Take a look at your handout now. Okay, i-highlight nyo na yung mga parts na nakalagay sa text yan. Hindi ko na ilalagay dito. I'll just discuss them straight. Okay? But look at the text. Highlight them now. Okay? In atrial contraction, it's preceded by the P wave. Okay? You're going to see an increase in your ventricular pressure, okay, ventricular pressure, the one in red, you're also going to see an increase in your atrial pressure, manifesting as the A wave. And you're going to see an increase in your ventricular volume, the one in blue. Ventricular volume will increase because basically, blood in the atrium is going to the ventricles. Okay, so slightly tataas yung ventricular volume. So what happens during atrial contraction? Okay, the first phase of the cardiac cycle, A wave, manifesting as an increase in your atrial pressure. You have an increase in ventricular pressure. You have an increase in ventricular volume. A wave. Okay, next. The next phase is this one. Okay, the one here in light yellow. That phase, second phase, is what we call isovolumic contraction. So, what happens here? Again, you always start with the ECG. Okay? In the beginning, there was a QRS complex. QRS is ventricular depolarization. Okay? Does it make sense that after ventricular depolarization occurs, that there will be ventricular contraction? Yes. So that will now manifest as the first part of systole, which is isovolumic contraction. During isovolumic contraction, let's see what's happening. During isovolumic contraction, ventricular pressure is increasing. That will manifest here in your red line, an increase in your ventricular pressure. Okay? However, during isovolumic contraction, ventricular volume remains the same. No change. Okay? The one in blue. So, bakit ganun, Doc? My ventricular pressure is increasing, but my ventricular volume remains the same. Why? Okay, the reason for that is physics. Remember I told you earlier, blood and air will only flow from high pressure to low. So, if you want blood to flow from the ventricles and into the aorta, sino dapat ang mas mataas? Si ventricular pressure or si aortic pressure? So, para mag-flow yung blood papunta sa aorta, dapat mas mataas si ventricular pressure compared sa aortic pressure. What's happening during isovolumic contraction? During isovolumic contraction, ventricular pressure is increasing. But it is still less than, the dashed line here, it is still less than aortic pressure. Okay? So, anong mangyayari? Walang change sa ventricular volume mo. Hindi may eject yung blood palabas into the aorta. Kasi mas mataas pa rin yung aortic pressure eh. So, classically, I tell my students, ang tragedy ng isovolumic contraction, tinimbang ka ngunit kulang. Ventricular pressure is increasing, but ventricular pressure is still less than aortic pressure. Okay? During this time, during isovolumic contraction, look at the text, highlight them in your handout. Okay? Ventricular pressure is increasing. Ventricular volume remains the same. During this time, you're going to hear the first heart sound. Okay? Caused by the closure of your AV valves. During this time, you're going to see your C wave in the atrial pressure curve. Okay? During this time, you're going to see the highest ventricular volume. Highest ventricular volume. Okay, next. At the end of isovolumic contraction, you're going to see the third and fourth phases. So what are those third and fourth? So that is your rapid ventricular ejection from this point up to this point. Okay? And reduced ventricular ejection from this point up to this point. Rapid and reduced ejection. So what's happening there? At the start of rapid ventricular ejection, hindi masyadong kita dyan sa handout nyo, but the red line here is over and above the dashed line. So the ventricular pressure here is now actually higher than aortic pressure. This will happen at the start of rapid ventricular ejection or at the end of isovolumic contraction. So if that is the scenario, okay, finally, may eject mo na yung blood. So what will happen? That will manifest as a rapid drop in your ventricular volume. Okay, so the red line is over above the dashed line. Boom! Okay, ventricular volume now decreases. And that is secondary to ventricular pressure being higher than aortic pressure. Anything rapid in the cardiac cycle will be followed by a reduced phase. So, dito initially, very sharp yung pag-drop. Ngayon, naging flatter na. So, this is reduced ventricular ejection. Okay? The highest aortic pressure, highest ventricular pressure will happen at this point between rapid ventricular ejection and reduced ventricular ejection. Highest ventricular pressure, highest aortic pressure will happen in here. Okay? May mali dun sa hindi naman mali. Hindi, mali basically yan eh. May misleading options dun sa Physio BRS questions regarding this one. Okay? I've listed that and I've given an explanation in the handout. It has something to do with the fact na hindi stinate dun sa option kung start or end ng phase yung pinag-uusapan. But dapat alam nyo to, okay? Tinuro ko naman, kapag tinanong saan highest ang ventricular at aortic pressure, technically, the correct answer to that is between rapid and reduced ejection. So, highest pressure will be at the end of rapid ejection or the start of reduced ejection. Okay? Kailan ka magkakaroon ng ventricular ejection? At the end of isovolumic contraction or at the start of rapid ventricular ejection. Okay? So, be careful. We're done with 4 phases. Let's now go, okay, to the 5th phase, isovolumic contraction, isovolumic relaxation. Isovolumic relaxation. Again, we start with the ECG. It is preceded by the T wave. T wave is ventricular repolarization. So does it make sense that when the ventricles repolarize, the ventricles will start to relax? Yes, it makes perfect sense, Doc. During isovolumic contraction, look at the red line. The ventricular pressure will decrease. Okay? Because the ventricles are already relaxing. However, take a look what's happening to your ventricular volume. Okay, ventricular volume remains the same. No change. So what is the reason for that? Okay? If we want blood to flow from the atrium to the ventricles and cause ventricular filling, sino dapat ang mas mataas? Atrial pressure or ventricular pressure? Based on the rule that blood and air will only flow from high pressure to low. If you want blood to flow to the ventricles and cause ventricular filling, sino dapat mas mataas? Dapat mas mataas yung atrial pressure. So let's see the figures kung ano yung nangyayari dito. Okay? In the isovolumic relaxation phase, ventricular pressure is decreasing. This is the red line here. Okay? However, it is still higher than atrial pressure, the dashed line here. Okay? The tragedy of isovolumic relaxation, when I tell to my students, is tinimbang ka, ngunit sobra. Earlier, sa isovolumic contraction, tinimbang ka, ngunit kulang. Sa isovolumic relaxation, tinimbang ka, ngunit sobra. Ventricular pressure is decreasing, but it is still above the limit. It's still over and above, okay, atrial pressure. So, no change in ventricular volume. Blood will not flow from atrium to the ventricles. Okay? During this time, during isovolumic relaxation, several things. You're going to hear the second heart sound, S2. You're going to see, okay, the V wave in the atrial pressure curve. Highlight this in your handout. You're going to see your incisura or dichrotic notch. Incisura, dichrotic notch. You're going to see the lowest ventricular volume during this time. So lowest ventricular volume will happen during isovolumic relaxation phase. Okay? So, Doc, pang boards na lang. Anong gagawin ko pag tinanong kami sa boards? This event will happen at which phase of the cardiac cycle? When all goes to hell and you absolutely don't know the answer, choose isovolumic relaxation. Chance will favor you, okay, because it has the greatest number of events. Preceded by T wave, okay, there's decreased ventricular pressure, no change in ventricular volume. You're going to see the V wave, you're going to see incisura dichrotic notch, okay, you're going to see the lowest ventricular volume. So a lot of events happen during that time, okay, during isovolumic relaxation. So chance will favor you kung absolutely you don't know the correct answer. Next, the 6th and 7th phase are rapid and reduced ventricular filling. Your 6th and 7th phase. So what happens here? Okay, this is your rapid ventricular filling. And this is your reduced ventricular feeling. Okay? Drooling. Okay? At the end of isovolumic relaxation, eto yon, that coincides with the start of rapid ventricular feeling. What happens? Finally, di masyadong kita, pero dapat naalala nyo, ventricular pressure, starting here, ventricular pressure is now less than atrial pressure. Nag-drop yung ventricular pressure mo to the point that it's now less than your atrial pressure. So when atrial pressure is now higher than ventricular pressure, blood will now flow towards the ventricle and cause ventricular feeling. Okay? The AV valve will open. Ventricular volume will now increase because of this ventricular feeling. You are now in rapid ventricular feeling. Okay? And then finally, after rapid, you're going to see your seventh phase, which is reduced ventricular feeling. Nag-slow down na yung pag-feel ng ventricles mo. Something to remember. The longest phase of the cardiac cycle is the last one. Okay? Reduced ventricular feeling, okay, that's the longest phase of your cardiac cycle. So, everything na pwedeng itanong sa cardiac cycle, na-discuss na natin. Nandyan sa handout ninyo. So, you don't need to read Physio BRS anymore. No more YouTube. Pagdating sa Physio na subject, eto na lang talaga yung Physio main handout. Of course, it won't cover everything in the medboards. Manghuhula ka pa rin dyan, especially for the crossover questions. The trivial questions, we won't be able to discuss at all. But it will give you a fighting chance. And sometimes that's all you need. For most students, fighting chance is what you need. This will give you a fighting chance for the boards and help prepare you for the life after when you go into residency. Cardiac cycle is something that you need to be able to teach your residents, that you need to be able to teach your medical students. Whether you go to Anis, to Derma, bilib na bilib ako kapag ang doktor marunong mag-explain ng pato, marunong mag-explain ng physio, marunong mag-explain ng basic sciences, at hindi lang magbigay ng diagnosis and management. Okay? So strive to be that physician who knows his basic sciences very well. So this summary table given by a former student, very nice. Okay? But na-discuss ko naman lahat ng pinaka-importante. Again, if we're going to quiz you about this, okay, atrial contraction, that is where you're preceded by P wave. A wave, you're going to see ventricular pressure, ventricular volume, atrial pressure will all increase. Isovolumic contraction, you're going to hear S1 preceded by QRS complex. You're going to see the C wave. Ventricular pressure is increasing, but okay, it is still less than aortic pressure, AOP. Okay? And rapid ventricular ejection, ventricular volume is decreasing. Ventricular pressure is increasing because during this time, ventricular pressure is already higher than aortic pressure. Slow ventricular ejection, na-reduce lang. Between rapid and reduced ejection, you're going to see the highest ventricular pressure, highest aortic pressure. Isovolumic relaxation is preceded by your T wave. Okay? Isovolumic contraction, relaxation, ventricular pressure, okay, is still more than atrial pressure. So even though ventricular pressure is decreasing, ventricular volume will remain the same. During this time, closure of your semilunar valve shall cause S2, the second heart sound. V wave is seen, incisura is seen. At the end of isovolumic relaxation, which coincides with the start of rapid ventricular ejection, ventricular pressure is now finally lower than atrial pressure. So you will now see a rapid increase in ventricular volume. Anything rapid is followed by reduced. So in the reduced ventricular feeling, this is the longest phase of the cardiac cycle. Okay? The last phase of the cardiac cycle. S1, S2, S3, S4, heart sounds. Okay? So, S1 is caused by the closure of your AV valves, mitral and tricuspid. S2 is caused by the closure of your semilunar valves, aortic and pulmonic. They will happen during isovolumic contraction and relaxation phases. S3 may be normal. You can see this in children, young adults, and pregnant patients. A previous board exam question. You will hear S3 during rapid ventricular feeling. S4, caused by vibration in the ventricular wall during systole, it will happen during atrial contraction or atrial systole. Physiologic split S2. Okay, what happens? Normally, the heart sound should be yung classic na lub-dub, lub-dub. But in physiologic split S2, the second heart sound will split. It will become like, hindi naman ganun ka-widely split, but you get what I'm saying. There's a splitting of the second heart sound. So what is the reason for that? Okay? The reason for that is an earlier closure of your aortic valve and a delayed closure in your pulmonic valve. Okay? So dahil earlier yung closure ng pulmonic valve, delayed yung closure ng pulmonic valve, magsisplit ngayon yung second heart sound mo. Kasi your second heart sound is based on the closure of those two valves. Bakit sila, Doc, ibang closure nila? Okay? Cardiodynamics, ibang effect ng inspiration. Physiologic split S2 happens during inspiration. Inspiration. When you inhale. So, ibang effect sa left, ibang effect sa right heart, ibang effect sa left heart. Okay? In the right heart, mas nasa-suck in ang blood, okay, papunta dito sa right atrium, right ventricle. So, meron siyang mas malakas na higop papunta sa right heart. So, pag mas malaki yung paghigop dito sa right heart, okay, sa right ventricle, mas marami yung blood, more than the usual, dito sa right ventricular and diastolic volume mo. So, ano ibig sabihin noon? Pag na-eject ngayon yung blood dyan, mas matagal bago mag-close itong pulmonic valve. Increased blood volume, delayed pulmonic valve closure. So, the higop is caused by the location, the intrapleural pressure, lahat, naghalo-halo. Dito humihigop, right side. Okay? Sa left heart naman, the opposite. Okay? Sa left heart, the effect of inspiration is that blood will tend to remain more in the vessels preceding the left atrium, and there will be less blood going to your left atrium and left ventricle. Less than what is usual. So, ibig sabihin nito, there will be less ventricular filling during inspiration. Less blood in the left ventricle means mas madaling eject yung blood papunta sa aorta. Kapag nangyari yun, mas mabilis magko-close yung aortic valve. Kung higop ang nasa right, dito sa left, sip lang. Sorry, sip lang siya, hindi siya higop katulad ng sa right. So, I used to joke with my students, sabi ko, nangyayari basically dyan sa right ventricle mo, pag nag-inhale ka, okay? Para siyang SM Mega Mall kapag Christmas. 'Di ba? Kapag Christmas, mas maraming tao. So, dahil maraming tao, they will delay the closure nung mall mo. Instead of closing at 10 p.m., they will close at 12. At dahil mas maraming tao sa loob, okay, ang tagal bago talaga isara yan kasi ang tagal nila bago lahat lumabas. So, Mega Mall, right heart. Okay? Resulting in earlier delayed closure, of your pulmonic valve. Okay? Delayed closure ng Mega Mall pag Christmas. Yung left ventricle mo naman, I used to joke with my students, mnemonic lang to guys, walang ma-offend ha. Yung sa left ventricle, para namang siyang mall na wala masyadong tao. Kunwari, para siyang Evergotesco Commonwealth. Kunwari lang, okay? So, yung Evergotesco Commonwealth, kahit Christmas yan, kahit ordinary day, konti lang yung tao. So, anong gagawin ng management? They will close it early to save on electricity. At dahil konti yung tao, mas mabilis siyang mapalabas, mas aga din mo din pwedeng isara. Okay, yung mall mo. So, Mega Mall and then Evergotesco. Higop and then sip. Earlier, delayed closure sa pulmonic valve, earlier closure sa aortic valve, resulting in splitting of your second heart sounds. Okay? So, these are murmurs naman. Murmurs are heard best at the following location depending on the valvular defect or valvular site affected. Okay? So, we know the mnemonic, it's always pray to Mary in a classic Z formation. Always pray to Mary. Murmurs involving the aortic valve, second ICS, right parasternal. Pulmonic valve murmurs, second ICS, left parasternal. Tricuspid valve murmurs, 4th to 5th ICS, left parasternal. And the most board relevant, murmurs involving the mitral valve, 5th ICS, left mid-clavicular line. Always pray to Mary. Mga klasiko, mga siraulo. So, pinalitan nila yung mnemonic. Ginawa nilang ayos, pare, tagay, muna. Okay? I've also listed classic case descriptions for valvular defects. A favorite in the exam, if you don't see this in physio, you might see this in patho, you might see this in pedia. So it will serve you well, hopefully. Nandiyan yung classic description nila. Some things I would like to point out, okay, that will help you. If you have murmur, tapos meron niyang increased pulse pressure or widened pulse pressure, or in a classic case, sasabihin sa'yo, pasyente natin may BP na 150/10, may BP na 160/0. Ganun ka-wide, ganun ka-increase yung pulse pressure. When you have murmurs plus that wide or increased pulse pressure, think of aortic regurgitation, or the synonym is aortic insufficiency. Classic yan, classic. The others are listed here for you to digest later on. Okay, I won't be able to cover everything in your handout, but I'll cover the most relevant in terms of what you need for general practice and in terms of what came out in the previous med boards to give you kahit paano impressions and fighting knowledge kung ano yung nangyayari before. So when you study now or when you take the exam, hindi kayo nagugulat. Kasi hindi kayo dapat magulat. Never expect the med boards to be perfect. It's super imperfect. It's a mixture, some easy questions, some hard questions. One day at a time, okay? If you feel, Doc, I'm getting overwhelmed, okay? Just relax. Contact your mentor or Mother Goose, okay? And really, just give it your best. I really believe kung ginawa mo na lahat, pag kinuha ka ni Lord anytime, if ever kunin ka ni Lord anytime, masasabi mo straight face na ginawa mo na lahat. Hindi ka na dapat nag-aalala eh. Useless eh. So, kahit ako noon, for myself, gusto ko lang masabi talaga na ginawa ko na lahat. Na parang hindi masasabi na tinamad ako, na aim lang ako to just do the minimum effort to get maximum result. I really gave it my all. Take comfort in that fact. Just concentrate as hard as you can, guys. Trust that we've gathered the best teachers possible, that we listen to students' feedback, try to improve the system, okay, all the time. Follow our directions and instructions. There's a lot of noise, a lot of advices, previous batches, other people. Ignore them all. Listen to us. Listen to our advice. Sa top notch lang muna. Tiwala kayo. Okay? Let's now go to a regulation of your blood pressure. Blood pressure. So, blood pressure is controlled by the vasomotor center of the medulla. If you remember our earlier lecture, the vasomotor center, okay, will be the one responsible for the control of heart rate and blood pressure. Now, in terms of the control of BP, there are several levels, several ways to control it. Acute control is done to the following mechanisms: ANS, baroreceptors, chemoreceptors, low pressure receptors, CNS ischemic response. And long-term control of your blood pressure is done via RAAS, the renin-angiotensin-aldosterone system. What you should remember, most of all, okay, acute control of blood pressure is mainly done, the minute-to-minute changes, via the baroreceptor reflex, and long-term control is done by RAAS. Why is that so, Doc? Bakit hindi pang acute short-term control ang RAAS? Because RAAS is hormonal, endocrine. It takes time for the proteins to be synthesized. Unlike the baroreceptor reflex, which is electrical, neural, it can act within seconds. So the baroreceptor reflex, okay, will utilize baroreceptors. Baro means pressure. Baroreceptors are basically stretch receptors. Okay, they are activated when they are stretched. Okay, and they are activated by changes in pressure. So this baroreceptor reflex will buffer minute-to-minute changes in blood pressure. Okay? Bakit ba hindi tumataas, bumababa ang blood pressure nyo every time you breathe? Every time you have inspiration or expiration? In theory kasi, because of intrapleural pressure, changes in intrapleural pressure, dapat nagbabago ang BP mo whether you inhale or exhale. But actually, your BP more or less remains the same, a map of around 100 millimeters mercury. And that has something to do with your baroreceptor reflex. You have two baroreceptors here, the carotid sinus baroreceptors and the aortic arch baroreceptors. Please differentiate this from carotid bodies and aortic bodies. This is carotid sinus, aortic arch. Carotid bodies and aortic bodies are chemoreceptors, not baroreceptors. So, these are basically stretch receptors. Carotid sinus baroreceptors will detect increases or decreases in blood pressure, while aortic arch baroreceptors will only detect increases in blood pressure. So, they send a constant firing rate usually to your nucleus tractus solitarius, the NTS, via cranial nerve 9 and cranial nerve 10. So, may firing rate sila, parang ping, 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 ping. Kapag ngayon nagbago yung pressure, okay, mag-change, mag-i-increase o magde-decrease yung firing rate nila papunta sa NTS, sa nucleus tractus solitarius. So let's give an example. For example, kapag mababa ang BP mo, madidetect ng carotid sinus baroreceptors yon, the one that can detect decreases in BP. Ayaw niya yon, ayaw niya bumababa ang BP mo. So pag na-detect niya mababa yung BP mo, magde-decrease yung firing rate niya, okay, through the Herring's nerve, through the cranial nerve 9. So, ping, ping, ping. Ngayon, si vasomotor center ng medala, nucleus tractus solitarius, basically, that's your vasomotor center. Maintindihan niya ngayon yung signal na yon, yung mabagal na firing rate. Maiisip niya, okay, mababa ang BP. Kailangan patasin. So, anong gagawin niya? I-activate niya ngayon yung sympathetic nervous system. So, anong gagawin niya, Doc? I-vasoconstrict niya yung veins. Okay, i-vasoconstrict niya yung arterioles. By vasoconstricting the veins via alpha-1, the venous vasoconstriction will cause, okay, an increase in venous return, cardiac output, blood pressure. By vasoconstricting the arterioles, you will increase your TPR, okay, increasing the blood pressure. So you vasoconstrict the veins, vasoconstrict the arterioles. The other two sympathetic responses is that it will increase the heart rate and it will increase your stroke volume. If you increase the heart rate and stroke volume, this will increase the cardiac output and again, increase your blood pressure. So kapag mababa ang BP mo, paano pinapataas yan ng baroreceptor reflex? It will stimulate the sympathetic nervous system, okay, to vasoconstrict the veins, vasoconstrict the arterioles, increase the heart rate, and increase the stroke volume. When those happen, okay, basically, blood pressure will increase. Okay? What if naman mataas yung blood pressure mo? Hindi rin naman gusto ng katawan. Kung mataas masyado yung blood pressure mo, there will be an increased stretch and that will now be detected by the carotid and aortic arch baroreceptors. So, bibilis yung firing rate nila sa NTS. Ping, 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 ping. So, ngayon si NTS, madedetect niya, maiintindihan niya na, uy, parang binigyan siya ng Morse code, no? Uy, mataas yung blood pressure, kailangan papabain. So, anong gagawin niya para pababain yung blood pressure mo? It will now activate the parasympathetic nervous system. The parasympathetic nervous system, dahil wala siyang effect sa arterioles and veins, wala rin siyang effect sa ventricular contractility, your parasympathetic nervous system will basically just do one thing to decrease your BP back to normal. Hopefully back to normal. It will decrease the heart rate. By decreasing the heart rate, you will decrease the cardiac output and you will decrease blood pressure. So, key points. Doc, pamboards, ano yung mga tinatanong dyan? Herring's nerve is the branch of cranial nerve 9. Okay? Carotid sinus will use cranial nerve 9. Aortic arch will use cranial nerve 10. Okay? Saan sila nagpapadala ng signal? Sa NTS, nucleus tractus solitarius. Pag mababa ang BP, anong gagawin para tumaas? Venous vasoconstriction, arteriolar vasoconstriction, increase the heart rate, and increase the stroke volume. Pag mataas yung BP at kailangan pababain, anong gagawin ni baroreceptor reflex? It will decrease the heart rate. Okay? So those are the things na mangyayari. Chemoreceptors can also induce changes in blood pressure. Surprise, surprise. In Respiphysio, we're going to discuss that chemoreceptors, when activated, they will usually increase the respiratory rate. They are activated by hypercarbia, by hypoxemia. Okay? However, chemoreceptors will respond kasi to the hypoxemia, hypercarbia that you have whenever BP goes down. So this will now have an effect of increasing our total peripheral resistance and increasing your blood pressure. Others, cardiopulmonary bioreceptors, these are the ones involved in your vein bridge reflex. Okay? A and P, claim to fame. A and P and BNP, okay, are the counter-regulatory hormone of aldosterone. If aldosterone will increase sodium reabsorption, increase water reabsorption, okay, and BNP will do the opposite. They will decrease sodium and water reabsorption. ANP is atrial natriuretic peptide. So it is produced by your atrium, the atria of the heart. BNP is brain natriuretic peptide. So you will think, Doc, naproproduces sa brain? No, it's not. It's misnamed. Okay? The BNP is actually produced in your ventricles. Ventricles. Okay? The cardiac ventricles is where you're going to find your BNP. Board relevant, elevated levels of BNP is the gold standard in diagnosis of left-sided heart failure. Okay? Next, the CNS ischemic response. The CNS ischemic response, what does that mean? Whenever you're about to die, when your BP, for example, is 15 to 20 millimeters mercury na lang, the CNS ischemic response is activated to cause vasoconstriction in all arterioles except the heart and brain. So what basically happens here is that pag nagkagipita na, yung brain mo, gusto niya, siya yung huling mamamatay, madideds. So gagawin niya is isa-shunt niya yung blood away from the liver, away from the kidney, away from the muscles, and just shunt it towards the heart and towards itself, towards the brain. Okay? It's the last-ditch effort by the brain to save itself. Kasi ang mindset ng ang evolution natin, pag na-deads yung brain, deads na rin naman lahat ng organs. So anong gagawin mo kapag nagkagipitan na? Halimbawa, tagal ng lecture ni Doc Bansuela, walk out, pause. Then habang hindi ka nanood ng lecture, bigla kang nakagat ng agad ka ng shark, agad ka ng whatever, sustained massive bleeding. So in that scenario, okay, if your BP now drops to that very low point, 15 to 20 millimeters mercury, blood is shunted away from all the other organs. Okay, they're shunted towards the heart and the brain. Okay, it's the last-ditch effort by your body to save itself. Starts at a BP of less than 60, optimal at a BP of 15 to 20 millimeters mercury. Okay? Long-term control, meanwhile, of blood pressure will have to utilize the renin-angiotensin-aldosterone system. Okay? So, what happens here? What's the sequence of events now? First, okay, you activate first the baroreceptor reflex before RAAS. You will only activate RAAS pag hindi enough or sufficient ang effects ng baroreceptor reflex to bring BP back to normal. So what will happen? Okay? There is a structure called macula densa. Highlight your handout. Macula densa. Okay? Found in the walls of your distal tubule. Okay? To be more specific, your early distal tubule. D to D, macula densa. Okay? Walls of the distal tubule. The macula densa is a sodium sensor. By detecting sodium concentration in the lumen of the early distal tubule, it is able to estimate for GFR and it is able to estimate for your blood pressure. So ngayon, pag mababa yung BP at hindi sufficient yung baroreceptor reflex, madidetect ni macula densa na mababa ang BP because of the decreased sodium concentration in the early distal tubule. Basically, tinitikman niya kung gaano kaalat yung lumen ng distal tubule. Tapos, sasabihin niya, pag mababa BP, mapakla, walang lasa. Okay, so mababa ang BP, kailangan ko pataasin. So, anong gagawin niya para mapataas yung BP? Tatawagin niya yung kapitbahay niya, si paring JG cell, paring JG, juxtaglomerular, found in the walls of your afferent arterioles. JG cell will now release renin. What is the physiologic effect of renin? It's a trick question. Renin has no physiologic effect. Renin is merely an enzyme that will convert liver angiotensinogen into angiotensin 1. Okay, what is the physiologic effect of angiotensin 1? None. Another trick question. Angiotensin 1 is merely converted to angiotensin 2 using the enzyme angiotensin converting enzyme or ACE coming from the lungs. Angiotensin 2 will already have a variety of effects listed in your handout, but the most important is that your angiotensin 2 will stimulate the zona glomerulosa, adrenal cortex to release aldosterone. Okay? Aldosterone will be stimulated to be released in the zona glomerulosa adrenal cortex. That aldosterone will have an effect on the salivary glands, sweat glands, large intestines. But the most more relevant is that it will have an effect on your kidney. In your kidneys, it's going to cause an increase in sodium reabsorption. It's going to increase your potassium secretion. And it's going to increase your H plus secretion. Potassium and H plus are sacrificed. They will be secreted into the urine so that you may have sodium reabsorption. Where sodium goes, water follows. So sodium reabsorption will be followed by water reabsorption. The increased sodium and water reabsorption caused by aldosterone will now increase your intravascular volume. That increase in intravascular volume, what will happen? It will cause an increase in venous return, an increase in your cardiac output, and ultimately an increase in BP. This is now the endpoint. Haba-haba ng storya ni Raas, but basically, pinataas yung BP pag mababa. So, ano yung sequence of events? Maculadensa, GG cell, renin, angiotensinogen to angiotensin 1, angiotensin 1 to angiotensin 2 using ACE. Okay, angiotensin 2 stimulates zona glomerulosa adrenal cortex, okay, to release aldosterone. Aldosterone will cause sodium reabsorption, potassium, and H plus secretion. The sodium reabsorption will be followed by water reabsorption, increasing the intravascular volume, venous return, cardiac output, and blood pressure. So that is RAAS in a nutshell. The sodium and potassium reabsorption are done using the principal cells of the kidney, while the H plus secretion is done using what we call the intercalated cells. So we'll discuss this again in renal physiology. Okay? Now, exchange of substances across the capillaries, it depends on what type of substance you are. Lipid-soluble substances will utilize simple diffusion, going from the capillaries to the interstitial spaces. Okay? Small water-soluble substances, including water itself. A previous board exam question. How are they transported? They will utilize the clefts or pores between the endothelial cell. Your endothelial cells, they make up your capillaries. They will actually have holes or perforations or clefts between them. These pores, take note, can widen through the use of histamine. So, edema formation, okay, caused by histamine has something to do with that, widening of the pores in your capillaries. Large water-soluble substances will utilize pinocytosis. So, let's talk about Starling forces. Starling forces, they operate at the level of the capillaries, and the spaces immediately surrounding your capillaries called your interstitium. We have four. Hydrostatic pressure, we have capillary hydrostatic, interstitial hydrostatic. Oncotic pressure, we have capillary oncotic, interstitial oncotic. Okay? When you hear the terms, hydrostatic is water pressure. Like a pressure ng water sa loob ng hose, okay? It's always directed out of the compartment. So, kung capillary hydrostatic, tingnan niyo yung arrows, palabas siya ng capillary. Pag interstitial hydrostatic, palabas siya ng interstitium. So, it's outwardly directed. Oncotic pressure, meanwhile, are attractive forces, inwardly directed yung force na yan. It's the ability to attract water using proteins. So, take a look at the direction of the arrows. Capillary oncotic, papasok ng capillary. Interstitial oncotic, papasok ng interstitium. These four, okay, if you place them in what we call your Starling equation, okay, you will get JV, your fluid movement. If JV is positive, it will cause, if it's a positive number, it will cause filtration. When you say filtration here, it means the substance will move from the lumen of the capillaries to the interstitium. Okay? That is filtration. If JV is negative, okay, it will now promote absorption. So ano naman yung absorption? It's the opposite. It's movement from the interstitium back to your capillary. Okay? I don't personally memorize the Starling equation. I utilize this drawing kasi ma-deduce mo yung Starling equation kapag nag-drawing ka capillary hydrostatic, capillary oncotic, interstitial hydrostatic, interstitial oncotic. Pag alam mo yung direction ng mga arrows, okay, you will be able to derive this. Now, word relevant. Take a look kung ano yung nandito sa Starling equation na to, this one. It's called KF, your filtration coefficient. Filtration coefficient is also called your hydraulic conductance. It describes what? It describes, KF will describe your capillary permeability. Capillary permeability. Okay? Just like what I mentioned earlier, in your capillaries, there are pores or clefts that's not permanent in size. Okay? Histamine, for example, can actually widen these pores. When it does, KF will increase. When it does, okay, there will be greater filtration. So KF is not a Starling force, but it can affect filtration. The lymph vessels. Again, the lymph vessels are drainage canals. 2 to 3 liters of lymph are produced per day with the following functions, mainly to reabsorb excess water and proteins in the interstitium, preventing edema, return it back to the blood. Lacteals will absorb fat via chylomicrons, and lymph nodes are there to involve in immunity and cancer. Edema. When you hear the term edema, basta basically nagbaha doon sa interstitium mo. May baha. Beyond the capability to return the excess fluid and protein back, to the blood. So, may either sobra sa water na nandoon, hindi na talaga kakayanin ng lymph vessels natin. Na may problema somewhere dun sa mga Starling forces or sa lymph vessels themselves. So, the cause of edema, in terms of your Starling equation, an increase in capillary hydrostatic pressure, a decrease in capillary oncotic, or an increase in filtration coefficient will cause edema. Increased capillary hydrostatic pressure, for example, left-sided and right-sided heart failure. Left-sided heart failure will cause you to have pulmoedema. Right-sided heart failure will cause you to have peripheral or ankle edema. So that is caused by, halimbawa, sa pulmonary capillary mo, mataas masyado yung pressure, pulmonary capillary hydrostatic pressure, magkakaroon kang pulmoedema. Okay? Decreased capillary oncotic pressure. For example, severe liver disease, magde-decrease ang albumin because albumin is synthesized in the liver. Protein malnutrition, not enough amino acids. So, not enough amino acids means decrease ang albumin synthesis. Nephrotic syndrome, you're wasting, you're excreting proteins to your urine. So, decrease once again yung albumin mo at the end of the day. So, decreased capillary oncotic pressure can cause edema basically by decreasing albumin. Okay? Increased filtration coefficient seen in burns caused by histamine or inflammation. Now, local blood flow control. Okay? How do we actually control blood flow at the level of the organ using arterioles? Diba arterioles can dilate, constrict. The arterioles are the main determinants of blood flow to the organ. So how does it actually do that? The answer is we don't know. We're not completely sure. We have hypotheses, your myogenic metabolic theory. The one that is more accepted right now is metabolic theory. Okay? Metabolic theory basically states that when organs experience hypoxia, a substance will be released that will cause vasodilation. Myogenic theory, mas mababaw When vascular smooth muscles are stretched, there's safer contraction and vice versa. Metabolic theory, pag hypoxic yung tissues, they will release a substance that will cause the vasodilation. Vasodilation ng arterioles means more blood, oxygen, glucose. What is that substance? We also don't know kung ano yung exact substance na yun. but the number one suspect is adenosine. Okay? So examples of metabolic theory are listed here: reactive, active hyperemia. Autoregulation of blood flow is an important concept. Okay? There are three organs that are autoregulated. When you say autoregulated ang blood flow nila, it means hindi sila masyadong pinapakialaman ng sympa and parasympathetic nervous system. The sympa and para will only come in times of crisis, like for example, massive blood loss. So these three organs are given autonomy. Okay? So these organs are your brain, your heart, and your kidneys. Okay, why were they given autonomy? Because for brain and heart, they are super important. Okay, the brain is the most metabolic organ in the body, requires a lot of oxygen, glucose, given its weight. The heart is needed for you to be able to pump blood to the brain and to everything else. While in the kidneys, it was given that autoregulation capability to regulate GFR, to auto-regulate GFR, to make it constant, stable na 125 ml per minute. Okay? Now, interesting application of the concept of auto-regulation. When I was a third-year medical student, I asked a fraternity brother of mine, sabi ko sa kanya, Bay, bakit pagkatapos kong kumain, why do I feel sleepy? Okay? Sagot niya sa akin, ganito kasi yan, Bay. Pagkatapos mong kumain, nagdadilate yung arteriole sa GI tract mo to be able to absorb the nutrients. Pag nagdilate yan, it means na shunt yung blood papunta sa GI tract. So it means somewhere along the way sa circulatory system, may nag-constrict. In this case, ang nag-constrict are the arterioles in your brain. Nung nag-constrict yung arterioles in your brain to shunt it to the GI tract, you now feel sleepy. Is the answer correct or not? Based on our concept of auto-regulation. The answer is wrong. Okay? It's not correct. Whether you eat or not, the blood flow to your brain will remain constant. It will have auto-regulation. Otherwise, guys, kung hindi auto-regulated yung brain, Diyos ko, ito yung gagawin ng mga tao. Pare, ang haba-haba ng lecture ni Doc Bansuela. Suicide na tayo. Tara, tol. Punta tayo sa buffet. Doon tayo mag-suicide. Okay? Kasi kung walang auto-regulation ng brain, okay, painless death ang kumain sa buffet. Okay? At least yun, masyashot na talaga yung blood away from your brain towards your GI tract. Goods na. So, the brain, you cannot do that. You cannot obviously commit suicide by eating sa buffet. Okay? The brain is auto-regulated. It will not, the arterioles there will not constrict if you eat. So, let's answer that. Okay, we do feel sleepy postprandial, but it has nothing to do with the vasoconstriction in the brain. It's hormonal. Initially, tama yung explanation ng Brett ko eh. Kapag kumain ka, nagdadilate yung arterioles sa GI tract mo to absorb the nutrients. That's correct. Tama din yung nag-shunt yung blood vessel somewhere else, ay sa GI tract, so nag-constrict siya somewhere else. Tama din yon. Ang mali is, anong arterioles yung nag-constrict to shunt blood towards the GI tract. It's not the brain that will constrict, it's actually the skeletal muscles. Yun yung magko-constrict para during postprandial to shunt blood towards the GI tract. That's why, di ba, sinasabi nila, huwag kang mag-basketball pagkakain. Okay, hindi dahil magkaka-appendicitis ka, by the way, that's BS. Okay? Hindi ka mag-basketball kaagad postprandial dahil you will not be able to run as fast, jump as high because blood is shunted away from your muscles. It's shunted towards your GI tract. You feel sleepy because postprandial blood glucose levels will go up. Okay? So when blood glucose levels goes up, insulin levels will also go up. And that insulin will then trigger the release of certain neurotransmitters in the brain to make you feel sleepy. This is to our evolutionary advantage. It's to ensure that pag may pagkain available sa environment at kumain ka, hindi mo siya kaagad i-burn. Okay? Mag-aalaw ka ng time to rest, okay, for you to properly digest and absorb the nutrients. That's why in our evolution, you feel sleepy. Okay? So, insulin increases, neurotransmitter responsible for making you feel sleepy will also increase. Angiogenesis will also increase as a long-term mechanism for blood flow control. Okay? You have increased blood vessels brought about by VAGF, FGF, and angiogeny. Okay? Vasoconstrictors and vasodilators. Important. Ang daming naka-highlight dito, Doc. Tinatanong ba ito sa exam? Yes. Vasoconstrictor. The most potent vasoconstrictor of them all is vasopressin. Okay? Yung anti-diuretic hormone. I'm well aware, Doc, bakit sa Schwartz, sa surgery handout namin, endothelin 1 yung nakausap. Physio textbooks, the most potent vasoconstrictor is vasopressin. Surgery, it's endothelin 1. Okay? Vasopressin can increase endothelin 1. Endothelin 1 is secreted when you have ruptured blood vessels. Physio, most potent vasoconstrictor, vasopressin. Okay? Serotonin is involved in migraine. It's also a vasoconstrictor. Endothelin 1, okay, released by damaged endothelium. For example, if you have wounds, injury. Okay. Vasodilators, prostacyclin is the one that will counteract thromboxane A2. Thromboxane A2 or prostaglandin A2, thromboxane A2 has two major effects: vasoconstriction and increase platelet aggregation. It's involved in MI and stroke because of this. So you have a natural counterregulatory substance for that, which is prostacyclin or prostaglandin I2. Nitric oxide vasodilates upstream blood vessels. It's a vasodilator. Okay? Next, prostaglandin or E are also vasodilator. Prostaglandin E1 and E2 are involved, for example, in dilating the ductus arteriosus. Okay? Lactic acid or lactate. Okay? Secreted, formed kapag meron kang anaerobic glycolysis from starving hypoxic skeletal muscles. Lactate or lactic acid can also cause vasodilation. Okay? So, anong mga importante dito? Lactic acid is the cause of pain, the cause of chest pain in MI, and the cause of muscle pain and muscle fatigue. The reason for that, lactic acid can stimulate pain receptors. So you produce that pag nag-MI ka, pag hypoxic na yung cardiac muscle, during muscle fatigue, it's produced also by the skeletal muscle when they starve for oxygen. Okay? In standing, take note of the sequence of events. Prolonged standing will cause pooling of blood in the extremities. So, in the lower extremities, to be more specific. So, there will be a decrease in venous return, cardiac output, and BP. This will then trigger baroreceptor reflex to stimulate the sympathetic nervous system. There will be an increase in heart rate, stroke volume, vasoconstriction of arterioles and veins. In exercise, cerebral blood flow remains constant. Blood flow to the heart and skin will increase. Blood flow to the heart will increase because of the increased demand. Nag-increase kasi yung heart rate mo and the-increase yung cardiac work mo during exercise. The skin arterioles will dilate. Okay? So, nag-increase yung blood supply ng skin arterioles mo. This is for thermoregulation, to cool you off. And then, the arterioles in the GI tract, kidneys, and non-exercising muscles will decrease. Okay? To shunt blood towards the heart and towards your skin. Okay? Hemorrhage we have discussed earlier, so it will activate the baroreceptor reflex and RAS to bring BP back to normal. Okay? So, that's it for cardiovascular physiology. If you have any questions regarding this topic, message me on Facebook. Pakilala po ng matino ha. Full name, med school, class number, okay? Your top-notch ID number. Then ask your questions. I'll gladly answer them. If I don't know the answer, I'll ask the other teachers for them to you. Sometimes I may call, okay, even do a Zoom chat to explain certain things. Maximize learning, okay, in an online environment. Watch the videos of Top Notch in a large screen as possible, whether it's your TV, projector. Hear it in the best sound possible. Wag yung headphones lang. Wag lang maliliit na speaker. Okay? So, kung pwede nyo i-projector sa TV nyo, or pwede nyo i-project sa projector, yun yung best. Para ma-feel mo na parang on-site siya. Okay? Thank you so much.